Okay. If everyone could take their seats. I don't think my microphone's working. Do you hear me?
Can everyone come in and sit down? We're ready to get started. Can we take our seats, please? So we can get started
We're
with the
starting the
scientific session.
afternoon session 2. Okay, our first presenter this afternoon, Dr. Bogatti. Does the type of pre-injury anticoagulant affect the outcomes in traumatic brain injury patients? A secondary analysis of a multi-institutional trial from the University of Arizona, and this paper is a Jack Barney finalist.
Hello, everybody. I'd like to thank the Southwest Surgical Congress Committee for providing me an opportunity to present our work. And I'd like to thank the moderators for introducing me to the audience. I have nothing to disclose. Traumatic brain injuries are responsible for nearly 30% of all the traumatic deaths. And according to this recent report from the CDC, there were nearly 64,000 TBI-related deaths in 2020. And there were over 2.5 million ED visits due to TBI. And the hospital costs range from $2,000 to $400,000 per TBI patient. And the report also mentions that from 2001 to 2010, there was nearly 60% increase in hospitalizations due to TBI, which suggests the increasing burden on the healthcare system due to the traumatic brain injuries. And this study reports that the rates of warfarin usage among trauma patients increased from 2.3% in 2002 to 4% in 2006. And according to the current standards, this number may be much lower than what it currently is. And as the population continues to age, the proportion of geriatric trauma patients presenting to the trauma bay also is expected to rise. And these patients are frequently placed on various medications, and anticoagulants are one of the most common among them. And traumatic brain injury patients using anticoagulants, when compared to those who are not on any medications, are known to have increased risks of ICH progressions, complicated surgeries, and mortality. However, prognostic significance of different anticoagulants remains unanswered. The brain injury guidelines were developed at the University of Arizona to help define and guide the management and triage of TBI patients by acute care surgeons. These guidelines use the patient history, neurological examination, and ICH characteristics to identify patients who do not require hospital admissions, repeat head CTs, or neurosurgical consults. And a lot of work has been done in the last 10 years on these guidelines, and they have been recently validated in a multi-institutional cohort, and they've been proven to be safe and reliable. According to the brain injury guidelines, patients using pre-injury anticoagulants are by default classified as a big three, triggering the most intense management, including hospitalizations, repeat head CTs, and neurosurgical consults. However, some questions remain. Do all the anticoagulants carry same risk of poor outcomes? And how do different anticoagulants interact with different ICH patterns? We aim to compare the effects of different anticoagulants on outcomes of TBI patients. This is a secondary analysis of the WAST big multi-institutional trial, and data was prospectively collected from 10 level 1 and level 2 trauma centers across the US. We included all adult TBI patients who were using pre-injury anticoagulants and those that had intracranial hemorrhage on their initial head CTs. We excluded patients requiring emergent neurosurgical interventions and transferred patients. Our outcome measures were intracranial hemorrhage progression, which we defined as a new or enlarged ICH on the repeat head CTs, and neurosurgical interventions, including craniotomy, craniectomy, ICP monitors, and EV drains placement. We performed multivariable regression analysis, adjusting for the following confounding factors. We had a total of 2,033 patients in our initial study cohort, out of which 1,437 patients were big three. Of these patients, 393 patients using pre-injury anticoagulants were included in the final analysis. 33 patients of those 1,437 patients were excluded from the study because of missing data on the type of anticoagulant. The most common medication used was aspirin, followed by Plavix, antifactor 10A, and warfarin. If we look at the baseline characteristics of the study population, the mean age was 75, majority were male, and 80% were white. The median GCS was 15, and the ISS was 16, and the median head AIS was 3. About 40% of the patients had loss of consciousness, 20% had abnormal neurologic exam on presentation, and 8% were intoxicated. 7% of the patients had non-displaced fractures, and 6% had displaced fractures. When we look at the hemorrhage patterns in the study population, the most common type of hemorrhage was subdural, followed by subarachnoid, intraparenchymal, and intraventricular hemorrhages. Coming to the outcomes, 20% of the patients had progression of hemorrhage on repeat head CT, and 10% required neurosurgical interventions. 8% of the patients had change in neurological exams, and the overall mortality was 14%. Patients using warfarin had highest rates of progression of hemorrhage compared to the other drugs. Also, patients using warfarin had highest rates of neurosurgical intervention requirements. On univariable analysis for progression of hemorrhage on repeat HCT among different bleeding patterns, warfarin was associated with significantly highest rates of progression of hemorrhage on patients with subdural hemorrhage, subarachnoid, and intraparenchymal hemorrhages. Similarly, on univariate analysis for neurosurgical intervention requirement among patients with different bleeding patterns, warfarin was associated with significantly higher risk of neurosurgical intervention need among patients with subdural hemorrhages. On multivariable regression analysis, we found that compared to aspirin, patients using warfarin were at nearly 3.5 times increased odds of progression of ICH. In addition to warfarin, neurologic exam deterioration, alcohol intoxication, subdural hemorrhage, subarachnoid hemorrhage, and intraparenchymal hemorrhage were identified as independent predictors of progression of ICH. Similarly, on multivariable regression for neurosurgical interventions, warfarin was associated with nearly 3 times increased odds of neurosurgical intervention. And in addition to warfarin, abnormal neurologic examination on presentation and SDH were other independent predictors of the need for neurosurgical intervention. In conclusion, different bleeding patterns were associated with different rates of ICH progression and neurosurgical intervention requirement among anticoagulated patients. And warfarin was independently associated with increased odds of neurosurgical interventions and ICH progressions. There appears to be a dynamic interaction between the type of anticoagulants, bleeding patterns, and outcomes. And further studies comparing different types and doses of pre-injury anticoagulants in TBI patients are warranted. I'd like to thank my mentor, Dr. Belal Joseph, and the Division of Trauma at the University of Arizona for their constant support. Thank you.
The discussion for this paper will be Dr. Alicia Mangrum from Honor Health in Phoenix.
All right, so we just had spent a great 3 minutes right before you talked, and it was great. So this is such a great paper, and I hope you don't record what I'm saying. I have my normal written thing for the American Journal of Surgery, but let's completely forget that, okay? But I do have a very nice written, very politically correct statement. Now, forgetting all of that, A, you did a very nice job. B, it was very difficult for me to understand a lot of what you said, but we had a little conversation. C, I guess I'm trying to think how to do this right. The thing I want to know is, okay, so we have all these patients that we take care of every day that come in on these, oral anticoagulants, and they're strong and healthy, like Tom White, for example, who do a marathon or hike up the mountains, or strong like me, I climb up Camelback, but yet we're on these oral anticoagulants. And then we get injured, or we have surgery, or whatever we have. And then when do we need to get back on the oral anticoagulants? When is the right time, as you asked me, when do you put me back on this? And again, I have a lot of questions that I have. I think the drinking is an issue, but I mean, people were drinking back in the 60s, the 40s, and the 30s, 1930, 1940. Is that really a question, or is it not? Do these people really have a fib? And that's why they're on, did they have a PE in the past? And for the audience, please forgive me because I know I'm going on and on. But you and I have had this discussion. When do we put them back on it? Yes, I agree. The big study, you pulled that data out, and just try to answer some of the questions that I know I took up to different levels.
Thank you so much, Dr. Mangrum, for the discussion. So basically the main aim for this study was basically we are classifying all the patients irrespective of their bleeds. If they are having anticoagulants, we're classifying them as big 3. So we wanted to see if all the anticoagulants are the same, or do they vary in terms of their risks. So if any big 1 patient who is otherwise big 1 but is put on big 3 due to their anticoagulants, can we try them and push them back to big 1 or not? So this was how the study started. And coming to the when do we place them back on the anticoagulants? I think this is there are no probably standard recommendations so far as of now, and I think some people do it in a week and they put the decision back on their PCPs. So I think a week or two, people usually start putting them back on the anticoagulants. And the indications for anticoagulants, basically about 50% of the patients were, nearly 40% of the patients were receiving anticoagulants in our institute due to atrial fibrillation, and around 10% were due to history of DVTs. So what part of them were actually needing these medications is not exactly known.
So we don't know where to put that on. We see it as a trauma.
Yes.
And then we stop it, and then they go home, and we have no advice to tell them in 2 months, 3 months, a year, you need to get put back on your oral anticoagulant.
Yes, that's the point. So the decision to restart their anticoagulant is under discussion, and I think maybe it is better for their regular physician to decide on when to restart their anticoagulants. Thank you so much.
Dr. Schrappel.
Shreveport, Colorado Springs. We did a very similar study with the MBIG a couple of years ago, presented in Southeastern Surgical with very similar results. Warfarin was very bad. It was much worse than the other DOACs. I think the bigger question is, though, did you look at reversal and how quickly these patients got reversed? Did they get vitamin K? Did they get PCC? Because I think that might be the bigger issue, because we've had some interesting extensions of leads with just vitamin K. It's supposed to work, but it probably doesn't work as well as it should. So PCC is a better option. But is that really what you're saying here, is we should reverse sooner and more aggressively than warfarin's just the worst thing, although it is rat poison? Thanks.
Thank you, Dr. Shipper, for the question. So basically, in our study, about 6.5% of the patients received PCC, and 5% received FFPs, and 6% received platelets. And when we performed the sub-analysis on patients that received reversal versus those that did not, warfarin was still the highest when it comes to the poor outcomes. So hence, we believe that these patients inherently deserve higher attention. And
Dr. Stewart.
Ronald Stewart, San Antonio. Really nice paper, nicely presented. These data line up with a whole host of other data that really lead to the conclusion that warfarin is significantly worse with respect to traumatic intracranial hemorrhage. I guess the only thing on warfarin's side is its cost, is its cost compared to the other agents. But to me, from a trauma standpoint, we had a lot of concern about these agents when they were released, the novel oral anticoagulants. And to me, it looks like it's actually the safest and almost, I mean, it's a little worse than aspirin, it looks like, but I'd be just interested in your thoughts with respect to warfarin as an anticoagulant and what we should be recommending to our primary care colleagues.
thank you, Dr. Stewart. That's a great question. So basically, a lot of studies are actually pointing out at warfarin as a major risk factor for the poor outcomes in TBIs. So what we believe is that warfarin is actually bad for these patients, and DOACs may actually be better. However, there have been issues related to compliance and costs when it comes to the novel oral anticoagulants compared to warfarin. But if we can maybe try to push forwards for more extensive use of DOACs, I think it may be better for the patients and for the trauma surgeons with dealing with these patients. Thank you.
All right, we got. So warfarin's the most quantifiable of those drugs to monitor the level of anticoagulation, and it would seem to be the most straightforward for reversal. Did you monitor INRs on these patients?
Thank you, sir. Unfortunately, we do not have the data on their INRs from the data set. This is one of the limitations of our study.
Okay, any other questions? Thank you.
Thank you so much.
Our next paper is FFP transfusion volume is associated with multiple organ failure following trauma, and the presenter is Jacob Odell from the University of Kansas.
Well, thank you for the introduction. Today we'll be talking about the transfusion of non-PRBC blood products in trauma and the potential organ dysfunction risk. I'll advance the slide. No disclosures. So a little information that everyone here knows. Over time, the modality of hemorrhagic resuscitation has changed, moved from a crystalloid model to a PRBC heavy model to sort of our current balanced component therapy 1-to-1 ratio we're all familiar with. Now, in some combination or even exclusively whole blood. So our non-PRBC blood components, FFP, platelet, cryo. Over the same time span, post-traumatic multiple organ failure, multiple organ dysfunction syndrome have been increasing in incidence. Some analyses have showed them to be the leading cause of late post-operative death in trauma patients. The etiology is incompletely described, but it's thought that immunomodulation is playing a key role. PRBC transfusion specifically, even this for a long time, even outside of the traumatic setting, has been shown to be immunomodulatory. And within the trauma setting, it's been demonstrated to be a risk factor for multiple organ dysfunction. The evidence for the non-PRBC blood products and organ dysfunction risk are less clear. For FFP specifically, there's conflicting information, conflicting results depending on the study you look at. Some studies would suggest there is an FFP-associated organ dysfunction risk. Others would suggest there's not. FFP transfusion, well, we think this is topical because plasma transfusion, even outside the setting of prehemostatic resuscitation, is being investigated in other settings, so its use is expanding potentially. So our study aim was to quantify the risk for organ dysfunction associated with the transfusion volumes of the non-PRBC blood products. We hypothesized that the transfusion volumes for plasma, platelets, cryoprecipitate would not be associated with development of organ dysfunction. We performed a retrospective matched case control study using NTDB data from 2019. We included all patients who received any volume of PRBC within the first 4 hours of admission. Exclusion criteria here, we excluded young patients, transfers, burns, those patients who received any whole blood, those who expired within 48 hours of admission, and those with missing critical data. So our explanatory variables of interest were the 4-hour transfusion volumes of plasma, platelets, and cryoprecipitate. Our outcome of interest, which defined our cases, was development of organ dysfunction as defined by any of the following: severe sepsis, ARDS, AKI. That's what's in NTDB. So our potential controls then, if those are our cases, are the patients who did not develop organ dysfunction. We did perform matching to reduce confounding between our cases and controls. We matched according to 7 known predictors of organ dysfunction. Those are age, blood pressure on admission, GCS on admission, ISS, the head and neck AIS score operative requirement, and first 4-hour volume of PRBC transfusion. For our numeric variables, they're matched according to the ranges seen on the lower right. For our analysis, we did compare our pre-matching controls to our match controls. We have that data. It's a little unwieldy to present here, but it's there. Our primary analysis then we're going to focus on is the match group. So that's cases and match controls. We performed univariate bivariate analysis and a logistic regression modeling organ dysfunction. So here's the central flow chart. There were over 1 million patients in the NTDB for 2019. Inclusion exclusion criteria dropped it to about 22,000, of which there were a little over 1,000 cases. Of the 20,000 potential controls, after matching, we had about 3,000. So our match groups at the bottom, a little over 4,000. So here is the comparison of our cases. That's sort of the middle column on the right, and our controls, which is the other farthest right column. The significant differences are in red. There's a lot of them because we're working with a really large sample size. So a lot of it's going to have to be teased out in regression. The red stars demonstrate variables upon which we matched. So we can see that cases were more likely to be male. They're more likely to have underlying comorbidities, and they were more ill upon presentation according to their vital signs, and notably their GCS and ISS, which we matched upon. So there's some residual confounding there. Here we see that patients who developed organ dysfunction were more likely to have a moderate or severe abdominal or pelvic injury, and they're more likely to require the operating room, including hemorrhage control procedures. Again, there's some residual confounding according to operative requirement. Here we have our transfusion data, followed by the outcomes on the bottom. So pretty simple for the transfusion data. Patients who developed organ dysfunction were more likely to require any amount of plasma platelets or cryo, and the associated volumes for each of those was higher. It was also higher for PRBCs. For our outcomes, 30% of patients developed organ dysfunction. according to our outcome. Acute kidney injury was most common, followed by ARDS and sepsis. And the typical outcomes in hospital mortality, ICU length of stay were longer or greater for the organ dysfunction group. So here's our logistic regression model. We took all the variables which differed between cases and controls according to bivariate analysis, included them in the initial model, and we forced the inclusion of our non-PRBC blood products. So for platelet and cryoprecipitate, if you look at the p-value on the right, we see that they have no significant association with the development of organ dysfunction. For FFP, that's not the case, has significant p-value. That's a per unit odds ratio. So for each unit of FFP, we observe a 7% increased risk in organ dysfunction development. This is a graphical depiction of that. So to contextualize this a little bit, there is precedent, even outside of the trauma realm, for FFP associated complications, things like trolley, hemolysis, infection. As mentioned, prior studies looking at FFP and multi-organ failure had conflicting results. Our results would support the studies which did find a multi-organ failure risk with FFP and would somewhat contradict others. It's more par for the course or chalk for platelet and cryo. Most studies don't show an increased multi-organ failure risk for those two components, and we didn't observe that either. Limitations, observational study, so we can't infer causality. The NTDB database has plenty of limitations. Our definition of organ dysfunction is not the same as those in the many comparison studies, and we're missing some confounding variables. So in conclusion, balanced resuscitation is life-saving, but our study is demonstrating some increased risk for organ dysfunction with FFP administration, and further investigation into FFP beyond pre-hemostatic resuscitation is indicated. Thank you to the Congress for having me and for having the privilege of the podium, taking questions.
Right. Our invited discussant is Dr. Hunter Moore from the University of Colorado.
All right, I'd like to thank Dr. Odell and his colleagues for a well put together manuscript and being in a timely fashion. And also, this is really important to rehash a historic debate on plasma transfusion. So in the 1980s, Denver and Detroit almost simultaneously published that preemptive plasma over crystalloid would be beneficial in people with major abdominal injuries. And that took almost 40 years before the first randomized controlled trial, and the only randomized controlled trial to show the ratios of plasma to red cell and potential benefit. Even though the study was negative, it suggested that 1-to-1 should be the standard of care, and most trauma centers have adopted that. But your paper is showing some potential harm. So this kind of fits the natural history of things that are discovered and get over-translated. There's a swing in the pendulum where we might be overcorrecting, and there is some observational data in the past that suggests different ratios may be better in different patient populations. So your group's findings specifically address this concern, but I have several questions for you guys, because if you're going to make these claims, you have to support it against some very good randomized controlled trials, including some prospective pre-hospital plasma studies that didn't show harm. The first is the methodology for the paper. You guys picked several variables: age, ISS, severity of head injury, red blood cell transfusion in a cohort of 29,000 patients with over 1,200 people having the primary outcome of organ dysfunction. However, after this controlling attempt, the case and controls weren't very well matched, and you had to use additional regression analysis. Do you guys think that using a propensity score match might help get better matched case controls before you make these assumptions with your analysis? The second is the 4 randomized controlled trials that came out in the last 5 years. It's really important to describe the limitations on those. Why do you think these 4 RCTs didn't show this harm that you saw in the plasma transfusion in this study? And finally, the manuscript didn't describe the crystalloid and total volume that everyone received. They had higher ISS, higher blood transfusions in the cohort that had organ dysfunction, where these people are just more physiologically decompensated, and that's why they developed it. If that's the case, would changing the resuscitation fluid have any difference in the outcome? I.e., if you give them whole blood, would it fix the problem?
Dr. Moore, thank you very much. Thank you for the responsiveness of the manuscript and for the questions. I think it's going to improve our data with subsequent analysis. So I guess taking them by pieces, your first question was about the imbalance in the groups and the potential utility of propensity matching. There is some imbalance or a significant amount of imbalance in the groups. What we didn't present here is in our bivariate comparison of our pre-match controls and our post-match controls. On all of our matching variables and other variables, we did see significant differences. So I think we're ameliorating some of the confounding. If but not all of it, obviously. For propensity matching specifically, it's an excellent tool. Our assumption was we wanted to look at plasma, platelets, and cryo. So if you're propensity matching according to the intervention, you kind of be restricting yourself to maybe one of those. So that was one reason why we chose not to employ it. Your second question, I was talking about some of the randomized control studies. I think trials like Combat, Pamper, Proper, and whether or not, they didn't demonstrate any increased risk in multi-organ failure for FFP. So how do we square that with our findings? First, although they had laudably like very excellent sample sizes for randomized control trials, it's not quite NTDB large. So, and they weren't powered for multi-organ failure. So if you look at the trends, I hate to use trend towards significance, but it was kind of headed that direction potentially for multi-organ failure. So it might be that we're uncovering, I guess you question this clinical significance, but maybe we're uncovering an effect there. And then you have to ask yourself, are they comparable populations? So for the pre-hospital plasma populations, those patients, obviously our population is probably not getting pre-hospital blood. So was it pre-hospital blood or plasma? It's confounding that we can't really square with ours. And then for all of them, the patients were more sick, significantly more sick. So we kind of speculate from this that maybe there is a small increased risk for organ dysfunction with FFP, but it might be that that's being diluted in really sick patients who have an overwhelming burden of injury. And that might be what we're observing there. And also they use more strict definitions for multi-organ failure. Obviously, ours was more lax because that's what the NTB had available. I think lastly, question about the crystalloids, whole blood. Crystalloids are a known risk factor for organ dysfunction. It's not available in the NTB. We'd love to analyze that further. And whole blood, when we looked at it, it's kind of difficult to analyze because right now it's not patients who get whole blood and patients who get component therapy. It's patients who are getting whole blood are getting some of that with component therapy. Not quite enough right now to analyze it, but we will do so further. Thank you, Dr. Moore.
Shrapnel, Colorado Springs, nicely presented. Did I see up there that you included AS at 6 in some of your patient populations? Because they're going to die related to their injury. So why did you include that in your study population?
Thank you for the question. I suppose in thinking about it, can't argue with the fact that those patients will expire regardless of what the intervention was. I think subsequent analysis should and will exclude those patients.
Nicely presented. One question that I had as well, in terms of the two populations, it seems like the patients in the organ failure group were much sicker, including a higher rate of requiring some sort of operative intervention. And did that also look at angiography and the risk of, because AKI was by far your highest organ dysfunction. Was there any correlation between the need for angiography and the potential for contrast-induced nephropathy that could have contributed in this group as well?
Thank you for the question. I think the long and short of it is with the limitations of this design, being able to conclusively say that certain factors aren't confounding our results, you can't say that. So I think certainly that's probably the case. I guess maybe it's optimistic, but teasing out the nuances, if you recall in the bivariate analysis, we did see differences, but a lot of those differences were then not present in our logistic regression model, which I think would suggest that it's accounting for some of those confounding factors you're talking about. I think operative requirement fell out, and definitely the need for hemorrhage control procedure fell out. Yes, thank you.
So I'm going to piggyback on that question. So AKI, I mean, massive transfusion can be a risk factor for that. I mean, how many of those patients progress to actually needing dialysis?
Thank you for the question, Dr. Gierman. I do not know the answer within our population or trauma generally, but I'm trying to think whether, I'm not certain that the NTDB captures dialysis requirement or new dialysis requirement. It might be a hospital complication. I'd have to go back to the data dictionary, but we can find that out.
That's what I would consider organ failure.
Significant, yeah.
AKI is just a lab.
Yeah, that's it. That is when we were performing the study, and when I think about it generally, even when I get up here to talk about it, in my head, it's like, well, does organ dysfunction, whatever we're calling it, is that clinically significant? Does that mean organ failure? The truth is, it's the best we could do. the NTB is not granular enough to diagnose or to use Denver, SOFA, Marshall scores over time. You know, if you look at how those define organ failure, they use the same systems though. You know, there's a respiratory component, there's a renal component, but I think it probably can't be overstated that these numbers and the extent of this is not multi-organ failure. It's organ dysfunction writ small.
Thank you, Jacob.
Thanks, Dr.
So
Gilman.
I think I forgot to mention this is also a Jack Barney finalist.
Our next paper is Risk and Timing of Postoperative Stroke, Thrombotic, and Hemorrhagic Events in Elective Surgery Patients on Perioperative Anticoagulation, presented by Dr. Zhang from Mayo Clinic, Arizona, and this is also a Jack Barney Award finalist.
Sabotage. Hello, my name is Chi Zhang. I'm one of the surgery residents from Mayo Clinic in Arizona. Thank you very much for the opportunity to present our work today. Perioperative management of anticoagulation is necessarily complicated because of the need to balance between thrombotic and hemorrhagic risks during this vulnerable period. While preoperative cessation guidelines are quite clear for these patients, postoperative guidelines almost all contain language something to the effect of restart anticoagulation as soon as possible per surgical team discretion. Additionally, current guidelines that do exist are based on literature that focus on patients who are starting anticoagulation for the first time and not necessarily patients who are preoperatively anticoagulated already. Therefore, the aim of our study was to evaluate the short-term outcomes of anticoagulated patients undergoing elective operations by detailing the incidence and timing and implications of the complications. We performed a retrospective analysis using institutional NSQIP data over a period of 10 years across 4 hospitals from 3 different states. Patient records were gleaned for complications as well as their anticoagulation resumption timing. Of note, therapeutic anticoagulation in our study was defined based on the dosing of each medication and not necessarily based on the circulating level. In terms of our inclusions, all patients who were anticoagulated for at least 3 months prior to their elective operations were included, and all of the surgical subspecialties that are captured within NSQIP were also included, except for cardiac surgery as well as vascular surgery. Patients who had heart valve placements were also excluded, as are patients who had characteristics that were associated with higher levels of care complexity. In total, we had 1442 patients who met inclusion criteria with a median age of 70. The majority of our patients were male, white, and were classified as having ASA class 3. In terms of our complication rates, of the 1442 patients who met inclusion criteria, 6% had either bleeding or thrombotic complications, 5% had bleeding complications, and 1% had thrombotic ones, including DVT, PEs, and strokes. Of patients who had bleeding complications, the majority required transfusions only, 1% required reoperations only, and the rest required both. In an overview of all complications experienced by our patients, the median time from operation to anticoagulation, as well as from index operation to complications, were both approximately 2 days. This is a graphic that represents all complications for our cohort. Across the top are postoperative days from 0 to 30, and along the y-axis are individual patients from 1 to 84. Red boxes are bleeding complications, blue are VTE events, green are strokes, and the gray, which unfortunately doesn't show up too well on this screen, are when patients are anticoagulated. Looking specifically at transfusion timing, 100% of our patients require transfusions within the first 3 postoperative days, and only 11% were on anticoagulation by the time they had their transfusion requirements. In terms of timing, most of the transfusion requirements occurred on postoperative day 1, and the median time from surgery to anticoagulation occurred on postoperative day 4. Looking at reoperations, anticoagulation tended to be restarted on postoperative day 2, and reoperations occurred approximately 1 week later. And 80% of patients were already anticoagulated by the time they required reoperation. For VTE complications, including DVT and PEs, again, anticoagulation was resumed typically on postoperative day 2, and VTE complication was diagnosed on postoperative day 9. Similarly, the majority of patients were already anticoagulated by the time their VTEs were diagnosed. Finally, for strokes, there were only 4 patients who were identified as having a postoperative stroke, and then 75% of patients had already been resumed on their anticoagulation prior to surgery, and 1 had a CVA event in the PACU before which it would have been even possible to resume their anticoagulation. Next, we examined non-NSQIP complications. In the bleeding complications group, 6 patients required ICU admissions, and there was 1 case of mortality. Interestingly, all of these patients had transfusion requirements and none actually required reoperations. 2 patients experienced strokes and lived with long-term sequelae, while the 2 remaining patients had no long-term sequelae. In the VTE group, all patients required medication dosing adjustment, but no other complications that were apparent in the electronic medical record. Of course, our research is not without fault. We're primarily limited by our sample size, as identification of our patients who met inclusion criteria depended on reliable documentation preoperatively. Additionally, while we hypothesized that postoperative strokes were rare, 4 is quite a small sample size. And this is perhaps related to the fact that we excluded patients who underwent cardiac as well as vascular surgery. However, their exclusion was also necessary because these patients require a more nuanced anticoagulation management, often with different INR goals or different DOAC dosing regimens. Finally, we focused on timing of anticoagulation as opposed to circulating levels. Overall, we saw that patients were more likely to have bleeding events rather than thrombotic events after elective operations, and more immediate reinitiation of their anticoagulation would have unlikely been able to prevent any further VTEs or stroke complications, as these already occurred once patients had already been resumed on their anticoagulation most of the times. Further research is therefore necessary for optimal timing of postoperative anticoagulation resumption. Thank you very much for your time.
This paper will be discussed by Morgan Bonds from the University of Oklahoma.
Hi, thank
Hello.
you to the Southwest Surgical Conference for allowing me to discuss this paper. And thank you to the authors for giving me the paper in a timely fashion. You know, this is obviously something that affects everybody in this room. I'm sure at some point in time, we've all thought, when should I start my patient's anticoagulation backup after their surgery? What's their risk of thrombosis? What's the risk of bleeding? So this is very pertinent to all of us. I do have a few questions. So I know you excluded people who had cardiac surgery and vascular surgery, but I wasn't quite clear on whether you excluded people who had had cardiac stents and were on like antiplatelet therapy, because those are usually the ones that I worry about the most. And kind of along the same lines, was there any data regarding the indication for anticoagulation in these patients? We kind of talked about it this morning in one of the sessions, that there are obviously people that are high risk for having thrombotic events, and people who are lower risk for having thrombotic events. So was there any data on that? And then finally, was there any data that you had collected on how long the anticoagulation had been held preoperatively, since the majority of your bleeding events appeared to happen on post-op days 0 and 1?
Sure. Thank you very much for your questions. I'll answer them slightly out of order. So in terms of indications for surgery, or I'm sorry, for anticoagulation, we included patients who were on anticoagulation for atrial fibrillation, hypercoagulable states with a diagnosis, as well as PEs, DVTs, and strokes. And this all occurred before their elective operation. And most of our patients were on anticoagulation for atrial fibrillation, which is consistent with general population data, as that is the most common diagnosis and indication for anticoagulants in general. In terms of CAD and stents, they were not explicitly included nor excluded. Like you said, for patients with cardiac stents, they tend to be on dual antiplatelet therapy. So if they had been included in our cohort, they would have been included because they were on anticoagulation for a different indication, one that we explicitly included. And in terms of how long medications are held before surgery, admittedly, there is some missing data in our cohort over a 10-year span, especially due to our institution changing electronic medical records kind of right in the middle of our study period. But when we looked at the distribution of complications over time by each year, there was no distribution differences. Additionally, there's prospective trial data on DOACs showing that despite every patient being told to hold their medications 2 days prior to surgery, their active anticoagulant levels were quite diverse. And there was no real pattern for which patients and which medications tended to allow patients to be more anticoagulated compared to another despite holding it for 2 days. And similarly, pharmacology studies have shown that when patients are started on warfarin for the very first time, it takes approximately 7 to 9 days for the patients to reach their goal INR somewhere between 2 to 3. However, when patients are resumed on that therapy, it only takes approximately 2 to 3 days. So that suggests also that there is some underlying level of anticoagulant that is still circulating within the patient, despite them holding it for usually 5 days.
Dr. DeSmaki.
Hi, Shimala Disnaga, Texas Tech. Thank you very much, Dr. Zhang, for that presentation. Very pertinent topic, as Dr. Bond said. So I'm going to disagree a little bit with your conclusion that the VTE rate was not related to resuming anticoagulation because they were on the prophylactic DVT prophylaxis, so the anticoagulation at the time of the VTE, because in your study, you showed that the median lag was 2 days, right? Which means some were probably a little bit longer. And so it's a little hard to argue that, say, someone waited 5 days to start the anticoagulation back and then got their DVT on day 10. It's a little hard to argue that even though they were on it at the time they were diagnosed, that those 5 days didn't make a difference. And so I'd be just a little careful in how you interpret that data, because I think looking at it retrospectively in a database, it's hard to make that distinction. What I would be interested to see is, because all your bleeding events happened as they always do right after surgery, right? That's what happens. They bleed the first 24 hours, we rush them back, we do what we need to do. It makes me think two things. One is that the preoperative cessation may have actually been the more impactful factor. And as you just alluded to, it's still in the circuit even after it stopped, and that varies based on medication. So did you look at those who resumed the anticoagulation on day 1 and whether they had an increase in bleeding events compared to everybody else? Because if the median was 2, then some must have been resuming it on day 0, day 1. Did those patients have the same, less, or more bleeding events than the others?
Thank you for that question. So we did not specifically examine patients who resumed their anticoagulation on day 1, but for patients who bled and only required transfusions, they were the median time to restart anticoagulation was 4 days. So that would have been on average 1 day after the average time for them to bleed, which was typically between day 0 to 3, usually 1. And then for patients who had reoperations for hematoma, interestingly, the median time for reoperation was actually on day 8. So it's unclear what the preoperative, that circulating level of anticoagulants effect is on the delayed hematoma presentation. However, for these patients, they were resumed on postoperative date. The anticoagulation for those who required reoperation were resumed on postoperative day 2. So for the transfusion patients, they were resumed 2 days after their complication, whereas for the reoperation patients, they had been resumed 7 days prior to their complication. So it is unclear, and that would be an interesting future direction for us.
Your cause and effect is probably flipped around in that first group, right? Because if you've had a bleeding problem, now you're going to delay your starting of anticoagulation.
Yeah.
So I think that's what you're seeing. Thank you very much for the study.
I agree.
One final quick question, Justin, and we'll move on.
Justin Regner, Temple, Texas. You presented a case cohort trial. In other words, you just chose patients on anticoagulation. Do you have any data for an age match cohort that did not have any anticoagulation to see what their bleeding risk, determine if there's truly an increased risk of bleeding?
We do not, but we can certainly do that.
Thank you.
Thank you.
Okay, our next paper is analyzing predictive factors for pathologic complete response for locally advanced rectal cancer, presented by Adam Clues from the University of Nebraska. And this is also a Jack Barney finalist.
All right. Thank you all for coming. Like you said, my name is Adam Close. I'm from University of Nebraska Medicine, and presenting analyzed predictive factors for pathological complete response for locally advanced rectal cancer. So for this study, colorectal cancer is the third leading cause of rectal cancer related deaths, cause of cancer and cancer related deaths in the US, impacting a large number of people, causing it to be a focus of research. In particular, we focus our research on locally advanced rectal cancer and analyzing predictive factors associated with the response to neoadjuvant chemoradiation. Now, neoadjuvant chemoradiation has become the standard of care for locally advanced rectal cancer for us. And historically, 10 to 30% of patients that undergo neoadjuvant chemoradiation experience a pathologic complete response defined as the complete tumor regression with no viable cancer cells in the pathologic specimen on final pathology. Then when they undergo their total mesorectal excision after their neoadjuvant chemoradiation. The multiple studies previously have demonstrated that PCR is associated with improved long-term survival compared to patients with an incomplete response and improved oncologic outcomes. However, multiple of the studies upon our literature review demonstrated that they were single institution undergoing certain rigorous protocols and certain pathways that end up resulting in smaller sample sizes. So the purpose of our study was to use a larger database to identify patient factors that are associated with or tumor characteristics that are associated with higher rates of PCR. So what we utilized was the American College of Surgeons National Surgical Quality Improvement Program, NSQIP database, using the proctectomy targeted databases, PUFs. So the NSQIP provides more granular data on rectal cancer surgery than what was previously available. And so this included the information that included the final pathologic T and M staging, the details if they underwent neoadjuvant chemoradiation before their final total mesorectal excision, and as well as information about the tumor distance from the anal verge based on pathologic examination with the final specimen. What we included was all patients with a clinical T3, T4, and 0 to 2 rectal cancers that did receive neoadjuvant chemoradiation, followed by total mesorectal excision from 2016 to 2020. Patients that were missing data such as undefined T staging or N staging were excluded from this trial, as well as I didn't mention on my bullet point, but any patients that had any metastatic disease, any M1 disease were also excluded from our data analysis. The analysis was done using SAS 9.4 and our p-value was less than 0.05. What our results showed us was that we had a total of 2,777 patients that were included in the study. 330 of these were found to have a PCR in final pathology, which was 11.9%. We did not see any association with the demographic factors such as race, gender, age, or ethnicity. Also, we found that it was not associated with T staging or tumor height. However, we did find that the pretreatment N0 staging was associated with a higher rate of PCR, 17.3% when compared to an N1 nodal staging, which was 5.4%, and N2 staging was 6.4%. However, when we analyze these broken down into T and M staging combined, we found that the T3N0 patients had the highest rates of pathologic complete response rates at 17.8%. And actually followed by them was the T4N0 patients at 14.2%. And then beyond that, it was T3N2 at 6.8%, and down the line, T3N1, T3 and T4N2 and T4N1 as outlined in this table. So our reported PCR rate was 11.9%, which was actually at the lower end of our literature review, with many of the studies reporting kind of a wide variety of a wider range of PCR rates ranging from 9.8% to as high as about 30%. And we believe that this is due to these single institution studies having very rigorous treatment regimens that they're undergoing with very specific chemotherapy regimens and radiation requirements, that this doesn't include the, this isn't representative of a large population sample, which would include patients that necessarily maybe are not completing all of their neoadjuvant chemoradiation and falling out of and having incomplete cycles before undergoing total mesorectal excision. And this also, this data that shows that our T3 N0 patients have the highest rates of PCR, followed by T4 N0. The T4 N0 patients that have a better PCR rates compared to the T3 N1s and T3 N2s indicates that pre-treatment nodal staging had a greater degree of association with post-treatment PCR rates when compared to this T staging, and that nodal status impacts the PCR rates to a higher degree than T staging. So the nodal status with, my apologies, I think I'm getting flustered. With differing response to primary tumor is consistent with previous studies that showed that that could impact the appropriateness of treatment strategies that include organ preservation, including watch and wait, as well as local excision after NA neoadjuvant chemoradiation therapy. Our study did have limitations. So we had using this database, we have a lack of standardization of the employed neoadjuvant regimens. So we weren't able to analyze which chemotherapy was being employed or what the duration or cycles of radiation was being employed in the neoadjuvant setting. It is unknown if our patients received TNT therapy or conventional neoadjuvant chemoradiation. And there is an unknown time between completion of neoadjuvant chemoradiation and surgery, which in previous studies has been shown to impact the PCR rates. And this is, as previously stated in the last presentation, the NSCOPE database is documentation dependent, requiring manual entry. So it is subjected to significant reporter bias and coding errors. So our conclusions is that the pretreatment nodal staging is an important predictive factor for pathologic complete response following neoadjuvant chemoradiation, and PCR rates did not appear to be associated with tumor location, patient demographics, or pretreatment medical diagnoses. This information can be helpful to guide preoperative discussions of risk and anticipated oncologic outcomes when discussing with patients, and may help to better define which patients can undergo tailored neoadjuvant therapy and or organ preservation after chemoradiation. These are my references. Thank you.
Discussant is Joseph Nasseri from Surgery Group, Los Angeles.
Adam, you did a good job. This is a pertinent topic for the simple reason, for two main reasons, right? One is patients have complete pathological response, have better prognosis. That's simple as that. But more importantly, in the last decade and a half, watch and wait has gained so much acceptance, and it's making its way into many of our practices. And that is validated by knowing how many patients would have truly have had complete pathological response to justify us watching them when they have complete clinical response. So I think that's why it's so pertinent. A couple of main issues with this paper is, one, using a database. You're answering an oncological, your outcome is an oncological outcome. And NSQIP is not geared to provide you with all the tools and all the variables that you need to completely answer that. Some of it you mentioned, right? Especially in recent years, there's the uptake of something called TNT. It's the total neoadjuvant chemotherapy, right? And it comes in various forms. It comes in consolidation. If you start radiation and chemo first, followed by chemo, or it comes in induction. There's different ways of doing it. And there's also different ways of giving radiation therapy. There's short-term radiation versus long-term. So there's a lot of granularity within how neoadjuvant treatment is being given, especially in the period of time that your study is being conducted. The second thing is, an important variable is the time between when the neoadjuvant finish and operation took place. You mentioned that as your limitation, but data has previously shown the longer you wait, the potentially increases the chance of your complete pathological response. The other few things that are missing that are likely pertinent in NSQIP is other oncological pathological variables, such as perineural invasion, lymphovascular invasion, degree of tumor differentiation, et cetera, that may also confound and affect your ultimate outcomes. So I think is the fact that you use the new database and the new variables with NSQIP, I think it does definitely shed a lot of light, and especially given shows how N status is more pertinent than T status. It may not draw or give us the full picture because of some of the missing variables. Two smaller questions is, why do you think the N2s fared better than the N1s in your data? I think they slightly did better than the N1s when it comes to complete pathological. And last question is, how is that going to change your practice? Are you going to be more or less likely to watch and wait people based on these variables that you studied? Or, are there more population you're more likely to say, hey, they have complete clinical response, I'm more confident that I could actually watch them. Thank you again, for large database, nicely presented, nice paper.
Thank you, Dr. Nassiri. In regards to the first question of why the N2 patients fared better than the N1 patients, overall analysis, combining T3 and T4 of analyzing only as N1 and N2, the N2 patients did end up doing slightly better. It was like 4.6% versus 3.6% for PCR rates when looking at N1 versus N2. I had thought about this multiple times and I tried skimming the data for it. I didn't actually come up with like a very solid reason for this as what would accurately or logically explain why the N2s would be doing better than the N1s, to be honest. That would be an interesting thing to analyze if possible in future research, but I don't have an exact reason for that. As far as if it would changing my practice, I think seeing the number of patients, like understanding that nodal disease can have a greater risk for an incomplete pathologic response after neoadjuvant chemoradiation makes me a little bit more weary approaching when considering watch and wait. I think having more data in the future will help support this, but when looking at these responses on imaging and on endoscopy and seeing that the primary tumor itself has regressed, understanding that there's a number of patients that maybe actually will have occult disease in the nodal basins or in the mesorectal nodes would actually steer me more towards doing a surgical resection. I know that there's some previous studies that had shown that there was like 7 to 17% of patients had actually had nodal disease on pathologic analysis, even though the primary tumor itself had completely regressed. I think there'd be an avenue for future research, but I think it would make me a little more hesitant without having and being more driving me towards doing a surgical resection without further data.
All right, in the interest of time, we're gonna move things along. Very nice job.
Thank you.
Our final paper of this session is anastomotic leak rates after repair of mesenteric bucket handle injuries, a multi-center study being presented by Dr. Sharmila Disanaki from Texas Tech.
All right, thank you. I feel like I have to start with an apology. This is the first time I'm presenting original research on a podium in a very long time. And the only reason I'm here is that my wonderful fourth-year med students who did most of the hard work are on a well-earned post-match vacation in Thailand. Not jealous at all. And so that's why I'm here pinch hitting. So you'll have to forgive me for any errors in that. So bucket handle injuries, familiar to most general and trauma surgeons, are when the mesentery gets torn, usually by blunt trauma, from a portion of the intestine. And these can be hard to recognize. There's usually some fluid in CT, for example, but often not peritonitis immediately, because what happens is that devascularized segment becomes ischemic and often results in a delayed necrosis and perforation, which then, of course, if not treated, can progress to death. Symptoms are often vague, nonspecific, and surgical management is usually resection and anastomosis. And the thought for this study was really because I noticed that colon bucket handle injuries in particular seemed to be having a higher leak rate at my own institution. So we looked at our own data, but not surprisingly, we didn't have the numbers to really get much out of it. So we reached out to friends, and I'll show you the institutions that participated later. And we decided to do a multi-center study. The anastomotic leak rates, not specific to bucket handle, but in general, are listed there, very wide range between less than 1% to 30% in the literature, assortment of risk factors, and really not a lot of good data on bucket handle injuries. So we wanted to compare bucket handle versus non-bucket handle intestinal injuries. And we wanted to look separately at small intestine and large intestine, because most surgeons know, in general, we consider colonic leak rates to be a little bit higher and a bit riskier than small intestine. So we have 12 centers participating. We only looked at adults. We used both univariate and then multivariate regression analysis. We calculated relative risk was our main outcome variable. So we had a good number of patients in this multi-center study, more small bowel as you might expect than colon. Just by sheer length of intestine, you'd expect that. And of these, more than half were bucket handle. And overall, the anastomotic leak rates were actually quite good in the study. If you look at that range, they're on the lower end of the range. So they're about 5% for small intestine and 8% for colon in bucket handle patients. Less in non-bucket handle patients, quite significantly less if you just look at the overall numbers. There's really no significant differences in baseline characteristics. I've put some minor variations there, but not anything you would really expect to change much. The small intestine group, interestingly, had a higher prevalence of shock, but otherwise the patients presented very similarly. As you might imagine, the majority underwent bowel resection and anastomosis. And we did initially see increased reoperations in small intestine, but once we went to the actual development of the model, we found that the only thing that was really significant was that colon injuries were 5 times more likely to have an anastomotic leak. And even after adjustment, that stayed significant. So 4.8 was the relative risk for anastomotic leak in colon bucket handle compared to colon non-bucket handle injuries. And this is important because if you remember, colon injuries tend to have a higher leak rate in baseline. And that just shows visually kind of when you look, almost everything else is right down the zero line. But when you get to the top, the anastomotic leak rate is greater in bucket handle injuries. The anastomotic leak was usually diagnosed in the second week. And I think this is an important point for us who manage these patients, that it takes a while for that leak to become manifest and for someone to do anything about it. Interestingly, the timing either of the initial operation or a delay in diagnosis did not increase the risk of leak. That was a little counterintuitive. We thought that it would. And overall, the outcomes were really quite good. There was no mortality difference, so that was reassuring. As you might expect, organ space infections shot up. If you have stool and enteric content leaking into your abdomen, yeah, you're going to get an infection. ICU stays and total length of stay went up. But ultimately, these patients were able to leave the hospital for the most part. We looked at sample size and we based it on an anastomotic leak estimate between 10 to 16% based on the literature. And that indicated we would need between 200 and 1,400 patients. And we had that, so lower end of it, but we met what we thought was a reasonable power analysis. It's not equally represented between colon and small bowel, but you wouldn't necessarily expect that because in the real world, injuries are not distributed evenly either. And so in conclusion, bucket handle injuries do seem to carry a significantly higher risk of anastomotic leak. This is especially true in blunt colonic injuries. The rate was 5% in small intestine, 8% in colon bucket handle, and no increase in mortality for those patients. So it's lower than we expected, honestly. We usually detect these in the second week after anastomosis. And ultimately, our conclusion of this group, and I'm interested to see what other people think, is that the potential risk of leak does not in our view, outweigh the disfiguring nature of an ostomy. And especially because we know in trauma patients, those ostomies often do not get reversed. And so our recommendation remains that an initial primary anastomosis is recommended even in bucket handle injuries based on the same criteria you would use in non-bucket handle injuries, and that we do not alter our practice purely because of that. These are the centers that participated. I really appreciate every single one of them. This is old school research pouring through charts. It's not as easy as a database, but we couldn't have ever got this granularity of data in any other way. And so thank you all to my collaborators and all the many co-authors of this study, and I'd be happy to take any questions.
This paper will be discussed by Wayne Anderson from CHI St. Alexius Williston.
Hi, I'm Bob Sticka from North Dakota also, but Wayne is here, but he's not feeling very well. And he asked me just a few hours ago, he asked me to do this. And since he's on my golf team tomorrow, I figured he'd give him the night off to get ready for the golf tournament. So
you gotta have priorities.
Wayne thanks the Congress for the opportunity to discuss this. He also thanks the authors for the nice for the review of the manuscript and congratulates them. He felt one of the strengths of the organization was their willingness to engage all members regardless of the locale of their practice, and he was very appreciative that they included some rural surgeons in the analysis. So the questions that Wayne had were, the study reports 910 patients, but I note there was 1,001 patients that were reported. Did these extra 91 patients have more than one bucket handle injury? Second question, is there any difference in the length of the injury? Are longer injuries more prone to leak, i.e. the size of the resection? Third question was, were all patients who developed an anastomotic leak treated with a subsequent stoma? And finally, with this knowledge, would you change your approach, i.e. would you recommend wider margins on your initial excision of the bowel? Would you consider using ICG to assess vascular insufficiency? And what should the approach be for a rural surgeon?
Thank you. Thank you very much for those. And I hope Dr. Anderson feels better soon. Yes, we did count each bucket handle separately. It explains that discrepancy there. We do not have data on length. As you might imagine, operative notes are not very descriptive. And I don't think even if we had tried to do that, we would have got enough accurate data. So we did not attempt that. As I've mentioned, we wouldn't change our approach with regards to ostomy, but I do think the use of adjuncts such as ICG, et cetera, could help. Now, the problem is we don't really know the time course. The fact that the leaks happened later suggests that maybe even if we did use ICG at the index operation, we wouldn't actually know whether or not. This is a retrospective review, it's hypothesis generating, and I hope we look into it a little bit more. I think these are all great directions for future research.
Dr. Mango.
Yeah, so of course, great, because you're presenting and not your resident. So quick question. What stapler did you use? I mean, we literally have a conversation about the Ethicon stapler versus, I'm not going to name the other staplers. And if you can't get the stapler that you're happy with, why not just use a hand-sewn anastomosis? I love the robot. I'm a robot fan. And you can still do that. So could it be a problem with not using the stapler that we used to?
I think that's a really intriguing idea, Dr. Mangelman. Thank you for that comment. We didn't look at this, but I kind of wish we had, because it's been a long time since people compared stapled versus hand sewn, because there was initial studies that showing it didn't make a difference, right? But kind of like you, I have a hunch that in some of these cases it does. And I personally hand sew a lot of my colon bucket handles. And so I'm a little biased to think that maybe humans can adjust for differences in thickness and things, perhaps a bit better. Stapler use, is it being used properly, especially with trainees who may not be familiar with some of these injuries? I think that's something we should probably, if we can, go back and look at, because it's a pretty decent sample size. It's the largest in bucket handle injuries we're aware of. I think that's a great point.
Dr. Stewart.
Ronnie Stewart, San Antonio. Great presentation, and I think really interesting. You asked for a comment with respect to bucket handle colon injuries and ostomy. I just, as part of Dr. Tim Fabian's festschrift, I just reviewed the past 30 years of colon injuries from Memphis. And I think their protocol minimizes the morbidity related to ostomy and minimizes leak rate. And it goes something like this, that for all destructive colon wounds that require resection, they get, if the patient has greater than 6 units of blood transfused or significant medical comorbidity, those patients are treated with resection, anastomosis, and diverting ostomy with a loop ostomy, which minimizes ostomy-related closure complications. And if the patient has none of those, does not have massive transfusion or pre-existing medical problem, then they're treated with resection and anastomosis without ostomy. To me, it makes sense, and their data strongly suggests you minimize ostomy while minimizing leaks at the same time.
Thank you, Dr. Stewart. And I think that's a very reasonable approach. We didn't see an effect of transfusions or some of those other classic risk factors in the study, but I think that's partly because surgeons were doing exactly what you described. There were patients, and I didn't go into detail with all of it. There were some patients who we excluded from the leak rate analysis who did have an initial ostomy. And I think the surgeons were self-selecting those patients who are very high risk and just taking them out of this category altogether.
Last question, Dr. Biffle.
Walt Biffle, San Diego. This is a great study and big numbers. So a real good opportunity to, number one, generate new hypotheses, but also potentially change some practice while we're waiting for those new studies. But to that end, we need a lot more information and start with hand-sewn staple because that question is far from answered. The confounding factors like some that Ronnie Stewart brought up, other things associated, pancreatic injuries, urine leaks, a bunch of things that people have put in to the various guidelines and algorithms. But I'd also ask for the definition of a bucket handle injury because I'm not sure what, how long a mesenteric defect makes it a bucket handle versus a mesenteric laceration. But the location of the injury is important too. Clay Berlew wrote the WTA open abdomen paper, and as you got further to the left, the leak rates were much higher. So with the colon injuries in particular, it's important to tell us which one, and was it the first relaparotomy, or the first laparotomy, the second laparotomy, the third when the anastomosis was done. So great opportunity with so many patients, and thanks for bringing that to us.
Thank you very much, Dr. Biffle. Real quick, you're right. This, I think, will spawn more data than I've presented here. We presented at East about risk factors for the leak, looking at the whole cohort of bucket handle only. Interestingly, if the first operation was a damage control operation, that ended up being the biggest risk factor for an anastomotic leak when you only considered the bucket handle and you didn't compare with the non-bucket handle. And I think that goes to the points that you and Dr. Stewart were making just a minute ago. I do think the hand-sewn versus stapled, I really wish, this happens every study I do. There's always a data point that I'm just so mad at myself for not thinking of beforehand. And that is the one for this one, is that I really wish I'd taken the method of anastomosis back in. And so we'll see if we can go back and rehash that. But yes, I agree. I mean, this is the largest data set, I think, out there on this topic, and we definitely should use it to full benefit. Thank you all for the privilege of presenting.
Thank you. So this concludes the scientific session, and now we'll have the presidential address. So we'll let people come in for that as well. Thank you.